I'm happy to go since I've
wait a while.
Yeah, I'm happy to go since I've got a few weeks worth of stuff to catch up on. Give me 1 second. I'm going to X out of one program here. I don't want Epic running in the background. Oh, come on. All right, what's it doing? It's giving me some weird remove confidential stuff thing. Gosh. Here, I'm going to leave and come back.
All right.
Oh, okay, so this is a case that was just shared to me by my colleague Stefan Tigas. So he posts interesting cases on Radiopedia. So we'll start off with this mass here on the radiograph, and here's a radiograph of the femur. So you can see a sclerotic lesion here, blastic lesion there, periosteal reaction, the Codman's triangle. So you kind of get the idea. This is, we're showing an osteosarcoma. So you go back to the CT chest. Here's the mass. It's a big kind of centrally necrotic mass, osteoblastic, invasive. The interesting thing here is that there is thrombus in the azygous vein. So most likely it came in through one of these intercostal veins. The thrombus traveled from the large met into the venous system, and then if you get down into the heart, you can see a big thrombus here, tumor thrombus, kind of coming in into the right atrium and kind of right on the valve.
Ooh.
So it looks like that's the metastasis from the femur.
Yeah.
Interesting. It looks bigger than the femoral lesion.
Yeah.
So I mean, has anyone? I've never seen seen sarcomas, but they originate in the renal, something like that has direct access. But I've never seen a met into the chest wall invade that extensively.
Yeah, and I'm not too familiar with this case. I literally just picked it up, but yeah, big met.
Yeah, that's cool.
Wow.
Okay. A few other really quick ones. This one's going to be probably the quickest one. This one is just a abnormality here. Just crisscrossing pulmonary arteries. You guys could probably see this not once in a while. I don't see it that often.
I think
and then, of course, and then there's another venous abnormality here. It's an aberrant left subclavian.
Oh, that's cool.
Yeah.
We've seen a couple of those kind of twisted pulmonary arteries, but then you throw in the bonus of that retro aortic brachiocephalic vein.
Yeah. And then so when I looked this up, it said that it's mostly like congenital heart disease associated or conotruncal abnormalities. But this patient, I don't think had anything like that. It's just, this patient was just a breast cancer follow-up case, no congenital heart disease or anything like that.
I was just going to ask you if there's any associations, but you read my mind, so.
Yeah, I didn't see anything. Okay, so this one, 30-year-old patient, diffuse ground glass, no pleural effusions, history of HIV. So this is a nice example of pneumocystis, pneumonia.
Ooh.
Maybe a few little cysts here. not too much. But I always like looking back on the the radiographs these patients come in, because it can be pretty subtle, in my opinion, to see some of this stuff, and can be missed. Often these are read often as negative, but you just kind of, I think the key to these is kind of looking at focusing between the ribs. There's you don't see normal pulmonary vessels here. It looks much fuller. You don't really see
Pretty
the normal.
subtle.
Yeah, very subtle. Yeah,
Yeah, if you window that, you might make it go away.
yeah.
Have you changed the window width in the center? Yeah.
What was her underlying risk factor?
HIV.
HIV. Was this a de novo presentation then?
Yeah.
Yeah.
Hmm.
Yeah, that's pretty extensive ground glass.
Yeah.
In the transplants where I've seen it, it's not been as extensive.
Yeah.
Upper lung and kind of spares the bases, but yours looks. I mean, if you present this as a chronic case, it looks like smoking-related lung disease or something.
Yeah.
So the interesting thing is that these cases, despite the subtle lung abnormality on imaging, is that they're really short of breath. So whenever I see this questionable lung abnormality and somebody's very short of breath, PJP just kind of leaps up to the top of the list.
Exactly. Yeah. They're hypoxic. Another very helpful thing is if you look at the labs, they come in with an elevated LDH. So you can look at the emergency clinician, the physicians at our county hospital know that, because we see a lot of pneumocystis, so they usually get that lab. So if you're reading one of these cases, you can look at the labs and check their LDH, and that'll kind of, if you're not sure what to call it, that I can help you sway one way or the other.
Oh,
And I'm not sure how the LDH is related. But I remember I saw that as before I even was doing radiology as an intern. One of the doctors sold me, one of the ER doctors, on my ER rotation. Okay, so last one I was going to show is, this one was just an impressive cardiac MRI I had last week. I'll show the 3-chamber. So LV function is decreased. And then the thing that jumps out is this trabeculation here. And then we can show some of the short axis. So you can see the extensive trabeculation here along the free wall, kind of sparing the septum, but as it persists as you get towards the apex. So this is a LV non-compaction. So you have a non-compacted layer here, which is really thin, and then the non-compacted layer, which is trabeculated layer here, and then the really thin compacted layer. That's all I have.
that's a nice example, huh? Wow.
Yeah, that's really pretty. Is there? Can you remind me? Is there some mutation that's associated with?
I don't know if it's a specific. I don't know. I don't remember. There's one specific gene, but it is a congenital. I'm not sure exactly how many genes are involved or how many mutations there are.
Right.
I don't know if it's not like one amino acid. I don't think it's.
No.
But I can look that up.
Okay.
Sure.
Sounds good. All right, Travis, you want to try again?
Yeah.
Thanks, guys.
Yeah.
I'll let you. Yep, there we go. Okay.
See a radiograph.
See a radiograph here?
Yep.
Yeah. So this is a patient that came into the ED hypotensive and has a probably pleural effusion, at least medium volume, maybe a small one on the right as well. Because of their hypotension, they went to CT. They didn't have trauma. Obviously, in the acute setting, a unilateral pleural effusion, you think about cancer, empyema, blood, no trauma. But this, I thought this was a really good call by one of my residents that you can see some of this fluid. There is fluid here. It's compressing the left lung, and a lot of it is high attenuation. Again, as we've talked about many times, and I'm still working on improving on a lot of these PE studies, is getting more contrast in the left side of the heart and in the aorta. But you can see in the descending thoracic aorta, as we get more inferiorly, that you kind of lose the wall here. You can see that it dilates out a little bit, and there's no fat plane here. It doesn't help that the patient is creating some streak artifact here. If we kind of get a little bit thicker slab, you just kind of lose the aortic wall here, and then you see something out here that you wonder, could that be displaced calcification of the aorta? And so they correctly were worried about a rupturing aneurysm, and they managed to do a venous phase, and sure enough, here you can see, this is, you don't actually see active extravasation, but this is all like rupturing thoracic aorta here. And so they were able to treat this with an endovascular stent graft, and the patient survived, fortunately. But again, I'm trying as hard as I can to get away from doing PE studies and this kind of early contrast, because there's so much information lost when you don't have contrast in the left side of the heart and the aorta, etc.
So Travis, where are you putting your ROI for your, I presume you're using some kind of like bolus tracking?
Yeah, so we had talked about this when I was at UCSF, and we had moved it to the left atrium. It's still on the pulmonary artery here.
Yeah,
and
we've been doing left atrium for a decade, and
yep,
it works.
Yeah, exactly. So yeah, we're trying. When you have 20 plus scanners and 150 plus techs,
Yeah,
but at least try even increasing our scan delay once the PA triggers can help. But yeah, for anybody out there that's listening, I totally agree with Jeff, and we had a lot of great results doing that as well.
Good.
All right, so here's an interesting radiograph, and this is a fairly youngish person. I think they're in their 30s. And I saw this one come across a couple weeks ago, and again, left-sided abnormality, and this weird opacity right here. So anybody, I know what the answer is now. So anybody have ideas here, thought process?
It's not bowel, is it? Or stomach?
That's a good thought, right? Yeah, I mean, it almost looks like it does look like a loop of bowel. And I'll tell you, when I first looked at this, I was wondering, could this patient have like a congenital diaphragmatic hernia that was never repaired, and have loops of bowel up here, and didn't know what exactly this was, if this was lung or more bowel.
I mean, it looks, at least on the radiograph, it looks extra pulmonary. It looks like there's a squashed left lung, and that's all a big pleural something.
Yeah.
Yeah, two areas of air that maybe are extrapulmonary in two places up there. Yeah.
Well, Peter was correct. It is bowel, and I'll just show it in reverse order. So that is her lung that is being compressed here. So she came in, unsurprisingly, with abdominal pain, and you can see this is all small bowel. And what's interesting here, pay attention to these omental vessels, or not, mesenteric vessels here, and see as they pass through the diaphragm, and you'll see that they transiently disappear right there and then come back. And so of course this hernia is lateral. This is not the site of a Bachtelek or a Morgagni hernia, and you can see the waist or the collar or whatever you call it here, and this is all dependent viscera. But this was incarcerated at this time. So this patient had, fortunately it was still viable, and they were able to reduce this bowel. And so that begs the question of why she has this. And I know we've shown plenty of trauma. We've shown either, motor vehicle crash, like unintended trauma, or iatrogenic trauma from surgery. And the interesting thing about her is that go back 5 years, and this was 5 years ago, and you can see here's the little diaphragmatic defect there, and this was described at the time and called correctly as a post-traumatic hernia. You still see some dependent viscera, and the reason I think they didn't do anything was this was being done for, she was having issues, abdominal issues related to her pregnancy, or having pain, or I don't even know why they did it. I don't think it was due to bowel in this hernia. But she delivered her baby and was fine for 5 years, and they was just kind of lost to follow-up. Now, what's also interesting is, let me make sure I get the right time. Let's see, that's this one. So she had been in the hospital at the original time of her trauma, which was 4 years before that. And I think, and actually there was another CT, and I don't think anybody would ever call that prospectively, but that's the defect right there. It's the same, near the same rib space at the time. She had a full chest, abdomen, pelvis. I guess I included the wrong study here, just a PE study. But this is all there was, a tiny little slip there that progressed over the course of a few years.
Wow.
Yeah, it looked like the entire small
and
bowel was in the chest.
I know. Yeah, and here she was, post-reduction. I think she had a little bit of re-expansion edema, but did well.
Yeah, gosh.
And then I saw this yesterday, which I think my first comment was, I don't know if I've ever seen anything quite like this. So, definitely looks like loops of bowel here, and it's overlined much of the chest. And I was telling my residents, because they're not old enough to remember the days of like double exposure of films or early, digital cassettes, but it's almost like they put somebody's bowel over their chest in this case. But we had a lateral as well, and let me see if I can find. And no, that's this is the lateral. So you can see this is all bowel, and it's anterior. And she's got a bunch of clips here as well. It's contained underneath the skin. But again, this is a middle-aged person who's had multiple cardiac surgeries and complications of cardiac surgeries that I'll show you. So I went digging in her charts, and let's see if this is, this was what I found from a couple of years ago in her chart. So she had mediastinitis and sternal dehiscence and ended up with a sternectomy from after one of her prior procedures. And even at that time, she had a small ventral hernia here. And the ventral hernia was containing portions of colon and portions of stomach. This is actually the gastric body and antrum coming through, and then it decompresses. And so this was known, but of course, over the last few weeks, it had been increasing. And the other thing that's interesting to note is there's a second small ventral hernia on the very inferior most images here. And so I called them. She was in the ED. She was having nausea, vomiting, and certainly was worried about obstruction and incarceration. And so you can see what she looked like yesterday. This is her stomach. And the stomach decompresses here, pinched by the liver right there. And then this is additional loops of her bowel still in there that are more dilated. But the kicker here was that she also had an enlarging hernia, and both of these were non-reducible on physical exam. And so I don't know which one is actually causing obstruction or if they both are, but 2 ventral hernias, both, and bonus horseshoe kidney here too. But 2 ventral hernias right now being managed conservatively. So
wow.
I don't know if anybody's seen a radiograph quite like that.
No.
Travis,
Yeah, but it shows, yeah.
Travis, on that previous case, do you think that the pregnancy might have caused the diaphragmatic hernia to enlarge? How far along was she in that, on that CT that showed the pregnancy? Was that?
That's a great question, and I would suspect it did. I mean, it was 4 years or 5 years ago that she had this CT, I don't know how to estimate gestational age on a CT, but you know, I can look up and see how far along she was. I'm not sure.
And then I wonder if she had a
But-
subsequent, maybe she might have had another pregnancy after that didn't get any radiographs and stuff. But you
Yeah,
know,
she had been lost to follow-up as far as I could tell. That's the one thing I did find. But yeah, I certainly think that probably did exacerbate this.
sure.
So, okay, let me show this arch because Howard brought it up. So I shared this one with a few of you weeks ago and had even forgotten about it until Howard reminded me. So, and David, I don't know if you got to see this one yet, or Jeff, but so we have an aberrant subclavian artery. It's a left arch. You can see left subclavian, left common carotid, right carotid. But the peculiar thing is that the right common carotid and the right subclavian have a persistent connection over here as well. And you know, it doesn't seem to be a true ring in the sense of a typical double aortic arch. There's no indentation on the trachea or mass effect. The esophagus isn't dilated. This patient has no symptoms. And so I guess the question is, what the heck do you call this? Because I'm wondering if this could be like a persistent right third arch as a communication between the two. But I have no, you know, otherwise I have no idea. And this was, I think, just a cancer restaging or something. This patient's had several scans where this has been on there.
Well, I've never seen it before, and in the aorta stuff I've worked on, I've never come across a description of that, but that's really cool. But yeah,
that's the problem. I didn't even know what to look for. Like, I didn't even know what to search. So,
you know, because in all the papers on aortic anomalies and stuff, and you know, years ago, I know David and I did a paper on one. I never came across anything like that. I've never seen it. Yeah, I mean, it's presumably some remnant of the, you know, the primitive arches, I presume, because they're symmetric. So you probably, and that's probably the explanation for the aberrant subclavian, right? I mean, it's fairly common that
yeah.
We see those. So it's that probably, you know, regression of a different component is probably the
Yeah.
but you probably normally don't need the connection because you already have blood flow. And it's like when you have, you know, a duplicated SVC, you often don't have a anterior brachius valve
Right.
really small.
Yeah, I mean, that's why I was just wondering if it could be like a persistent, you know, branch of the right third arch rather than the fourth arch, as an explanation for why it's not clearly is not behaving like a vascular ring.
Right. Very interesting.
It's interesting, of all the, you know, millions of CTs that have been done, no one's seen it before.
Yeah.
Yeah.
Or just recognized it. I picked up on it.
David, any thoughts?
I'm voting with you guys. I like your idea of a persistent third arch.
Okay. Yeah, I showed it to some other folks and nobody had any better ideas. So I don't know, just another curiosity.
It's kind of a diminutive aberrant subclavian, which kind of goes with, you know, it never fully developed because it had the other
Right.
supply.
Right. Yeah.
But
all right, and then I'll show.
So there was not another connection of that artery to another piece of the aorta, was there? I mean, it's only fed by the aberrant subclavian.
Oh no, well there's the connection here, right? So the right common carotid still arises here. So the connection to the arch is here and all the way here as well.
Okay.
Yeah,
that's perfect because the downstream vessel there is much fatter than the right subclavian. So that's good. Yeah. So then it's a parallel component in parallel with the normal entities that arise from the fourth arch. So I like your idea of a persistent third arch. Be nice to have,
I'll finish with this
be
one.
nice to have a 3D reconstruction of that, if you could, because I think that might show it behaving in a parallel kind of way.
Yeah, yeah. I'll see, they've had a few, they're all just routine contrast enhanced studies. I'll see which one is best that can maybe get rid of the streak.
Okay.
So I'll show this one really quick here. This is probably, it's one of the more interesting lung cancer screeners I've seen in a while. One of my colleagues saw, let me get rid of this sync. So this is the study that she saw, and I thought this was a really good observation. This is the left subclavian artery, and it's full of stuff, calcium, and it's a little expanded. And you can see how it all extends into the lumen of the aorta. And so, you know, we've shown this in the abdominal aorta when you see like a coral reef aorta. And she saw that and saw that, you know, it looked honestly worse than a couple of years ago, especially the portion in the aortic arch. Like, it was hard to see if there was actually a lumen to this aortic arch. And I can NPR this really quick just to drive home the point. And then I'll show you the subsequent CTA, because you know, I was reading the CTA to follow up a lung cancer screener, and when I just saw the indication, it was like follow-up arch abnormality. I was wondering why they got a contrast enhanced study, but you can see the only place where there's not calcium is really right here, a small little channel of a few millimeters. And so it really does look like one of these porcelain or the coral reef aortas. It's like proliferation of atherosclerotic disease in there. So, and here's the subsequent CTA that was done, and the left subclavian is chronically out. But sure enough, you can see this lumen. There's not much space left in here. You know, I can do a reformat of this as well, and it's a small little channel. And so the question is, have you guys seen this, or is there a better term than, you know, just coral reef aorta for the arch like this? Because that's, you know, that's what's left of the lumen right there. And she, interestingly, you could see her left common carotid is pinched at its origin. You know, she has some other areas of similar looking stuff extending into the lumen. My friend Costa at Mallinckrodt, you know, he said they recently had a patient similar to this where they did a full arch bypass. But it was the first time he had ever seen it. I'm curious if you guys have any experience with this.
No, I've never seen one in that location.
No.
So typically it's in the descending aorta if it's in the thoracic aorta. And these people usually have peripheral vascular disease. Does she have peripheral vascular disease, leg problems?
Not that we know of. I mean, this just, you know, we didn't even image it. It's this is the problem, right? It's a little bit, she clearly has abdominal aortic disease, which was only partially included on this study as well. So she's a vasculopath for sure. Her celiac is out. You know,
And is she a smoker? Yeah. Does she have emphysema, Travis? Is she,
yeah, well, she's definitely a smoker. She was a lung cancer screener, but you know, you wouldn't know from looking at her lungs themselves, but she definitely qualifies. So at least 20 pack years. I'm not sure how much.
Seems like she has an MI too.
What?
Oh yeah, she's had a looks like a good observation. She's probably had a basal, you know, inferolateral wall MI. Plus she's got a lot of lipomatous hypertrophy. I think in her 60s.
Okay. So it's coral reef aorta. I think, you know, it's the right context for everything. It's just surprisingly proximal.
That's the northern hemisphere one. All right.
All right. Well, thanks for everybody's input.
All right. Howard, do you want to try to go?
Sure.
Jeff, could you try me first, because I'm anticipating I'm going to have to reboot everything. So could we just test
Go
at
ahead.
this point? I'm not getting your permission here. Let's see. Here we go.
Yeah.
Let's see if it works. Can you see a radiograph?
Good.
Okay.
Yep.
Shall I just go ahead? I've just got two quickies.
Sure.
Oh, yeah.
We got plenty of time.
Okay. So this person has a pretty normal looking chest radiograph, does have an anastomosis lobe, has a port catheter in place. and has this CT scan from, this is from November, and here we see the nice azygous lobe, and everything is well behaved. And then subsequently had another CT scan, and this is now December. And now we can see that this azygous lobe, this is a very aggressive azygous lobe, and it's decided to move up into the neck and accompany the trachea here. So we have this apical herniation of an azygous lobe. So I bet you guys have never seen that before.
Definitely not.
And can I show you a coronal here? You will.
Sure.
I think this brings it out pretty nicely here. So we have this apical herniation. So I'd never really encountered apical lung herniation before, and evidently it's the sort of thing that comes and goes. People will have apical herniation if they do a Valsalva maneuver or cough that reduces itself spontaneously. They usually do not strangulate up there. And there is this explanation here in terms of, this is from Paige McAdams years ago, showing this stuff that's called the Sibson's fascia here, which can evidently stretch and allows the lung to go up into the neck alongside the trachea. So this is a right-sided phenomenon. This person just happens to have an azygous lobe, but otherwise it's an apical hernia. These things usually reduce themselves, and I don't think that there is any treatment required. There have been some pictures in some of these articles of showing the person with a bulge alongside the trachea, but I'd never encountered this before. Have you guys seen these apical hernias before?
Never.
Yeah.
Never.
Okay.
So,
A little
so I was going
lung up
to,
there, but
yeah. So David, I was going to mention Paige's article because we had a case about a year ago of a pediatric patient, and they actually, I'll try and get it because they actually have fluoro of the apical lung hernia.
Okay.
Reducing itself. And so it was the Peds folks saw it, and then Paige had mentioned his article. He'll love this case.
Okay.
are there any risk factors
So,
for it? I mean, if this patient had any neck surgery or anything, or
No,
okay,
no, nothing like that. And we had a number of CT scans in the past, and it had never happened before. So I think maybe she just decided to do a Valsalva for this particular CT scan. You know, hold your breath, and sometimes people bear down when they do that. So let me show you this this other person here. This this man came in short of breath and had a positive RSV test, and you can see that he does have this. He's a patient who's had chemotherapy for leukemia and has had a transplant, so he's immune compromised, and he has this diffuse lung disease. So if you told me that this was pneumocystis, I'd say that's great for pneumocystis, but this turns out to be RSV, and it got worse. See, at this point, it's really denser now in the upper lungs. At this point, he had a CT scan, and you can see that he's got this extensive ground glass abnormality in upper lungs, and then he's got a lot of bronchiolitis. So as we get down lower parts of the lung, we get away from the ground glass, and now we've got these smudgy small airways everywhere we look, and goes down into the bases. So there's a lot of bronchiolitis with this. And I had one other case of RSV that also had predominantly a bronchiolitis pattern like this, with little smudgy small airways shadows. And this person that had an earlier CT on admission, when this person first came in on November 30th, there was already a CT abnormality, but it consisted of just a few small patches of ground glass in upper lungs, and just a little bit of bronchiolitis in left mid lung. And now that the things have really gotten a lot more dramatic, particularly the bronchiolitis pattern, I think has really taken off here. So this is what RSV looks like, and this is the sort of person who's likely to get the lung disease from RSV, being immune compromised. So it's typically the very young or the old or the immune compromised that get RSV in their lungs, and not just as an upper respiratory infection in their nose and throat. So last week I showed you guys a case of influenza in a otherwise healthy young man, a 29-year-old man who was admitted and then had, really circulatory collapse and was put on ECMO. And that man's lungs have just fallen apart completely now. The lungs are densely consolidated, and then he's developed a cystic abnormality throughout the right lung, and then he's gotten big pneumothoraces and things like that. So influenza A can be devastating even in a young person. So last week's case of influenza has really just gone down the tubes. I'm not sure he will survive. Okay, that's all I wanted to show. Thank you.
Thanks, David.
Thank you.
All right, Howard.
Am I the last person to go, Jeff, or how much time do I have?
There's 20 minutes, and I have 3 cases that aren't too long.
Okay. Let's start with this one. I'm not showing it in the exact order, but at this particular point in time, let me just go back here. We start off with a patient that has a defibrillator device on. You can see a malpositioned object there. And then we can see that that is properly positioned and is now in the right ventricle. So just that alone should alert one to the notion of a pacemaker malfunction. And the patient having received a temporary but acutely pacemaker lead into the right ventricle. And when you see that, it should alert one to do the following, which I think I've shown a couple of cases before, but I always tell my residents, when you're evaluating a pacemaker, and particularly when there are findings and history to suggest a problem, what you've got to do is you've got to go to costoclavicular space, and you've got to zoom in, because the costoclavicular space is by far the most common location for a disruption. And you've got to mag in, change the window width, and I hope you guys on your computers will see there's a gap right here between here and there of the broken lead. And I'll just show you another image. So again, you have to really get in there. I think maybe one, and it can be pretty subtle, so not that one. Let's try this one. Now, of course, it could project in a way that makes it hard to see. No, that's an old one. Let me try this one again. But there's the gap of about 1 centimeter of the broken lead from here to about there. I hope you can appreciate that. But you're only going to see that and confirm the break if you both zoom and change the window width to really bring it out right there. So they replaced that lead, put a new one in. They didn't extract that one, they just put a new one in for that broken lead. The next patient is a history of a person that, I don't think this is the scan, but apparently had this discovered as an unexpected finding in the context of either cardiac CT or coronary CT. And the patient was asymptomatic from this lesion that was discovered. And you'll see how metabolically active that is. And that is weird. FDG avid, pulmonary mass, differential diagnosis for that. Doesn't touch the pleura, but when it's this hot, one should think of a sarcoma particularly. And this indeed is a synovial cell sarcoma, primary of lung. And we've shown cases like that many times before. So synovial cell sarcoma discovered as an incidental finding. I showed these two together because this is a different lesion, and this patient was symptomatic. So I'll show the coronal because it corresponds nicely with the coronal FDG, which I'll show you. So here's a big mass. You can see that there is pleural fluid, but you can appreciate the size of it here and its attenuation characteristics and the way it's pushing on things. And let me bring in the coronal PET here, the comparison, which is this. And unlike the previous one, this shows that it's not very active, just a little bit orange, but not very much. So a nice correspondence. So again, it's a differential diagnosis of a big pulmonary mass, but not very FDG avid. And this turns out to be this unusual entity. Any guesses? It's not a pulmonary solitary fibrous tumor. It's not an inflammatory myofibroblastic tumor. It's not a sarcoma.
How about a bronchogenic cyst?
Water, no, it looks solid.
What sort of attenuation was it, Howard?
Pardon?
What sort of attenuation values do you get from it?
Let's do that. What is that, 25?
Yeah, that's not bad for a mucus-filled cyst.
30. But, you know,
You
it's got
expect an effusion with a
cells in there
bronchogenic
that
cyst.
are taking up and metabolizing glucose in the interior, right? Albeit not very hot. Make those go away.
Not a pneumocytoma, is it? Usually those are much smaller.
A solitary pneumocytoma, that would be really big for that thing.
Yeah.
I would definitely not have made the diagnosis here. So here we go. It's interesting. Look at the pathology description, which is really interesting. You can see it's spindle cells, low cellularity, arranged in loose fascicles. It's got all these negative, mostly negative things for all kinds of cell surface receptors. And this is the one that they do for synovial cell sarcoma, the previous case. But ultimately, they decided that this was a desmoid type of fibromatosis lesion.
Wow.
So let me show you that. So desmoid tumor, benign neoplasm, incidence is X amount. Local recurrences are common, they say there. The location where we usually see that is in the abdomen, not in the chest. And about 5 to 10% of these are associated with familial adenomatous polyposis. And what else? I just copied and pasted this, I think, from Up to Date or someplace like that. But I think it's maybe the first, maybe I've seen one or two in my entire career, if I remember correctly. And I can't remember if it was like this or was this big in the chest.
I mean, I've seen about 3 or 4 in the chest wall, but they seem to, they usually are more muscle attenuation and kind of, you know, work their way between the tissue planes. I've never seen it as like a discrete mass.
Oh. Interesting, huh?
Yeah, very strange.
Yeah.
So it was, so where was it located exactly? I mean, where this it says mediastinal on the path report.
I think, you know, I don't have the op report, but I assumed it was just in the lung. Well, no, I don't know that it's in the lung because it's pushing lung aside. So correction, I don't know exactly where it is.
So is the other name for this, would the other name for this be inflammatory pseudotumor?
No, that's different.
Well, because they're saying in the description there, they're saying it's low-grade myofibroblastic neoplasm, which is, do you see that, Howard? If you go in your pathology,
Yep.
it says low-grade myofibroblastic neoplasm. So to me, that's the inflammatory pseudotumor when I Google that, because I remember that had the same name.
I can't remember if this is included in that spectrum of lesions that is called inflammatory pseudotumor in the chest.
Yeah.
Yeah, I mean, asthma is, yeah.
The most common of those usually is a lymphoplasmacytic process that produces the so-called inflammatory pseudotumor. They're clearly intimating that this is in the category of desmoid lesions. Type lesion. Desmoid type fibromatosis, low-grade spindle cell. Oh. No, here's described as mediastinal. So I take that back. That was just compressing things.
Slightly
Okay, let me see which other one I have. Okay, I'll just show you this one really quickly. I don't know whether in your institutions you see venous ECMO cannulas that kind of look like this commonly or once in a while.
Okay.
Yeah, we see it here.
Okay.
Yeah.
So I've always used, I don't usually use product names for medical devices, but typically I would use the product name Avalon cannula for this, which is a single cannula, 2 lumens, and they look very similar. So I've always been describing this recently as Avalon. And then one of the folks in the cardiovascular section who, an RN who's kind of in charge of the devices and teaches about them, kindly said to me, I know it kind of looks like an Avalon, but just for your information, we don't use the Avalon anymore. We use another one called a crescent. So here is the anatomy of this thing called a, let me fix that up, crescent device. And I'll show you some things about it. So it has 2 lumens, this crescent, because this other lumen here is crescentic and kind of stable. And let me show you a couple more things about this. She actually came down and allowed me to take a photograph. So this particular cannula has got, it's bicable. So there are intake holes or ports, SVC, IVC. The return or reinfusion port here in this animation, you can see the blood coming back, is located, of course, between the two. And I'll make this bigger now. The reinfusion port is this right here. So we have markers 2 and 2, but as I'll show you in a moment, at the level of this reinfusion port, 3 little black dots that mark the site of this thing. And I'm going to make that smaller again. What they would like to happen, the manufacturer, is that they would like the reinfusion port here to face the tricuspid valve. And I don't know too much about this topic. I have to read more about this topic, but with venous ECMO in general, there is a potential issue to do with recirculation. So if too much of the returning oxygenated blood bolus is taken up by any one of the ports and recirculated extracorporeally rather than going forward to oxygenate the body, that recirculation phenomenon can become a problem. So the manufacturer of this particular one says that you should try to be sure that the port here, the reinfusion port, faces the tricuspid valve. So let me show you that. Now in practice, I'm not sure how critical that is, but that's sort of the general idea. So let me go here and X out of that. And now show you a couple images. So I've got 2 cases. Let me just show the other one. with this and pick out one of these. Shoot, didn't want to do that particularly. So the idea is you have to try and identify the 3 markers for the reinfusion port. And let me pick out another one to see if I can show you this. That doesn't show it well. Okay, so in this particular case, you can see that this little divot right here is actually that reinfusion port, except in this particular patient, and I asked him about this, it's facing the wrong way. So you'd like the 2 marks in this one to be this way, so that this reinfusion port right here faces exactly this way, and is on this side of the cannula. Now, they may not change its orientation in a particular patient, but at least reading from the manufacturer, they try to tell the operators to put it in such a way that you can see these 3 dots, and you want ideally this reinfusion divot, that port, to face this way, not that way. Because in theory, you know, all the blood coming out of there, I don't know in practice how much it actually happens, but if the blood comes out here and some of it goes up there and some of it goes down there, it's going to be taken up by these ports and recirculated, rather than what you want is you want the whole bolus to go that away. So again, I haven't read up enough about that to know whether in clinical practice this is always a problem, but I thought I would just share the anatomy of this crescent cannula and explain the 2 little marks there. Have you guys heard about that or noticed that? I hadn't before. She brought this
very
down to me.
informative.
Shoot,
Yeah.
the new writer.
We'll definitely be keeping an eye out for that, though. Thanks, Howard.
Yeah, so it's kind of interesting. And it was all news to me, so I read up about it a bit and then saw the whole recirculation thing, which I know nothing about really. I have to read more about the potential problem of recirculation in venous ECMO in general, and how they deal with it and diagnose it and so on and so forth. All right, Jeff.
When it's the side ports, facing the wrong way, they just rotate it, or did they have to?
I haven't gotten that far. I don't know if they'll actually rotate it. They might decide, well, you know, based on the oxygenation, we're happy with it, so we don't think recirculation is a problem, in spite of the fact that the side wall is pointing the wrong way, and just leave it. So, because I imagine that taking it out and rotating it could be a non-trivial thing.
Yeah, well, I don't know if there's like a sheath or something they can just rotate it in.
No. Yep.
Yeah, you're right, because that one's pointing immediately.
Yeah, the other one is pointing correctly, so I'm going to try and bring that up, and you can see the divot appearance of the port facing the right way, and the 2 little dots. Now, with beam angulation and bedside radiography, it's going to be sometimes hard to see that and figure out exactly what you're looking at. But in this particular circumstance, you can see that it's at least facing the right way.
It might be easier to hold the catheter stationary and rotate the patient.
Yeah, really. So that's kind of cool anatomy of a cannula that I was calling by the wrong product name for who knows how long.
Thanks for explaining that, Howard, because we have a catheter that looks just like this, but I didn't look for dots on it. So I'm going to go back and look for
Yeah, and
dots.
see if they're using the crescent rather than the Avalon. I think those are the only 2 that are manufactured, as far as I know, for venous ECMO like this.
Good to know. All right.
Sorry, I took up all your time, Jeff.
That's all right. I'll save them for the next time. Speaking of